This is a 3-minute summary of the paper that we just published in Sociology of Health and Illness. So as you know, social prescribing involves linking patients in primary care with services provided by the voluntary and community sector. It is being widely adopted internationally and especially in the UK as part of the NHS long-term plan. But what is the expectation of social prescribing? We see across the literature that social prescribing initiatives often have different aims, different priorities. There are different ways of measuring success, and also different understandings of what success in social prescribing means, right? So we decided to undertake a literature review to explore how social prescribing is framed and understood in the literature, and most importantly, to investigate whether, and if so, how these different ways of understanding social prescribing influence the way services are designed, delivered, and evaluated. So what the real implications of these framings of social prescribing are. And we reviewed academic articles and literature and used discourse analysis. So across a total of 89 studies, we identified 3 different ways of understanding social prescribing. Some studies emphasized increasing social inequalities behind escalating health problems and presented social prescribing as a response to the social determinants of health. Others instead problematized people's increasing use of health services and depicted social prescribing as a means of enhancing self-care, independence, and reducing their reliance on further care. And others stressed the lack of human and relational dimensions in general practice, which was often depicted as fragmented, impersonal, very rushed as well, and claimed that social prescribing could restore personalized care. So interestingly, discourses circulated unevenly across different type of studies and article sections within the literature. For instance, discourse 2 was quite dominant and used consistently to design, measure, and interpret social prescribing, which had actually real implications in the way services were delivered, usually one-off, with boundary setting strategies in place to prevent that dependency, and with a very strong motivational and coaching component. We also identified a shared tendency across the 3 discourses towards framing social prescribing as a solution to complex and contentious problems, actually social and health system problems, such as social inequalities, overstretched health services, increasing fragmentation in general practice, and critically, this contributed to an oversimplification of the realities of the problems being addressed and also of the delivery of social prescribing itself. So we end by suggesting an alternative care-based framing of social prescribing, which understands the provision of holistic, sustained, and accessible primary care, not so much as a means to an end, as a solution, but as an end in itself. And maybe from a research perspective, this would require shifting the attention of research from measuring impact to evaluating the extent to which social prescribing may or may not succeed to support people in greatest need, while also contributing to stronger, fairer healthcare systems. So to sum up, we've seen that how social prescribing is understood has relevant implications for service design and delivery. We've also seen that current ways of understanding social prescribing may contribute to oversimplify both the realities and problems being addressed and also constrain the way interventions are delivered and evaluated. And we propose, lastly, an alternative care-based framing of social prescribing, which prioritizes and evaluates holistic, sustained, and accessible practices within strengthened primary care systems. Thank you very much.